I liked the brain and the spine, neuroanatomy, neurophysiology. And I like working with the kids. I really enjoy that dynamic. I like working with families and helping those families get their child through a difficult process. I didn't, but at a relatively young age, I was attracted to medicine. So I thought, even when I was sort of in middle school and early high school, I had a good idea that I wanted to pursue medicine.
Gotcha. What kind of factored into that decision for you? How did you know at that age?
Well, my father was a surgeon, a cardiac surgeon, and so I had exposure to the field of medicine and specifically surgery at a young age. And he was a great model example for me. He liked his work; it brought him satisfaction. I saw that, and so it made medicine and surgery a very natural thing. I was interested in surgery and I was interested in public health, but whether that was going to be another surgical subspecialty, I wouldn't learn until towards the end of my second year. And I got exposure to the neurosurgery service. My first year, I really did enjoy neuroanatomy, neurophysiology. I thought that was really exciting, but it wasn't until I got my first exposure with the neurosurgery service that I really became attracted to it.
So what was that first exposure like? Was it seeing a case? Was it working on a research
Yeah,
project?
it
Just
was a
talking.
2 week. Yeah, this was at Yale. This was a 2 week rotation in the Yale neurosurgery service. And it was a very involved 2 week time. I got up early and rounded early with the team, saw how they ran rounds. I certainly went to the OR with them every day, but I really was attracted to the teamwork that I saw amongst the residents there. I mean, it was sort of an all-in mentality. They were close with one another, dealing with very complex, very sick patients, and I thought that was really cool. I knew at that point that neurosurgery would be a good fit for me. Rewind about 4 years earlier, when I was an undergrad at Notre Dame, I spent a year in East Africa teaching at a primary school. And on the weekends, I found an opportunity to work in an HIV/AIDS clinic. And that was really my first exposure to that type of medicine. While I went there initially to be a primary school teacher, I quickly found that most enjoyable days were the days that I was spending at the clinic. That sort of confirmed my desire to go to medical school. And in entering medical school, I knew that type of work, that type of public health work and service was something that I had to do moving forward. And to that end, it made it when I found neurosurgery, I struggled for a brief period trying to understand where that Venn diagram overlapped, namely the
Mhm.
public health and the neurosurgery circles. And that's a different story.
Yeah. So at that stage, what was the field of global neurosurgery like? I mean, it seems like it's taken off over the last 10
Yeah,
years or so. Where
it
was it then?
wasn't. It really wasn't a thing. There was this term global neurosurgery was not in existence at the time. I mean, this is back in 2008, 2009. So there were a handful of individuals that were doing things like short-term trips, but there was also one individual in particular who had invested himself in neurosurgery in the public health space that I got connected with, and that really drove uh, the next 7 years of my life. Cerebrovascular, the sickest patients, incredible anatomy, and I could see that it was a field that was quickly evolving and innovating, and I thought that was really exciting.
Yeah.
Reed Thompson was a big one. He's the chairman of neurosurgery at Vanderbilt. Jay Wellens, who's the chief of pediatric neurosurgery here. He had a big part of me finding pediatric neurosurgery. And then outside of Vanderbilt, Dr. Ben Worf, who is in Boston, he had a tremendous impact on my decision to pursue pediatric neurosurgery, and then within pediatric neurosurgery, finding opportunities there.
So this is a question that I personally have. So I spent a year at UAB, and one thing I noticed is that even the pediatric neurosurgery department, there seems to be particular focuses for the individual providers in the department. Is that the case at all pediatric neurosurgery departments, or is that only the case at large pediatric neurosurgery departments?
I'm not sure I understand your question. Say again, there's a
So,
specific.
so at UAB, for example, Dr. Johnson seems to handle most of the tumors and the vascular
Oh, I see.
complications. Yeah, and like Dr.
I
Wright does a
understand.
lot of the spine. Is that the
Yes.
case only at large centers?
Uh, well, yeah, I mean, it is the large centers that have multiple pediatric neurosurgeons that have the luxury of subspecializing. But yeah, it is the case, especially over the last 5 or so years, where the bigger centers are subspecializing, where one surgeon will kind of take ownership of a particular disease process or subfield within pediatric neurosurgery. And we've done that here at Vanderbilt as well. Tumors and vascular neurosurgery. So things like AVMs and moya moya, which affect children. But all of us treat some of the general pediatric neurosurgery conditions like hydrocephalus and spina bifida, as well as pediatric neurotrauma. Probably spend 40% of my time doing general pediatric neurosurgery and 60% doing either the neuro-oncology or the neurovascular component. The third year and rotated through the pediatric neurosurgery service. By the end of that time, I was pretty confident that pediatric neurosurgery was where I wanted to be. Yeah, well, it was a time where before that, global neurosurgery was not really a well-defined field, but we saw that there was a great need to develop it, and so with a lot of different collaborators, we one of the first things we did was try to understand the global burden of neurosurgical conditions, and so we spent a lot of time doing epidemiology type research in neurosurgery. That was done simultaneously with, I was spending most of my time, which was back in Uganda, doing pediatric neurosurgery clinical work and pediatric neurosurgery research. Couple reasons. So things like neurotrauma, huge burden of disease abroad. Infections, CNS infections, we know has a huge disease burden. Some of that is neurosurgical, some of it is not. It is the case that the vast majority of the literature derives from high-income countries, and the vast majority of things like neurotrauma and CNS infections, the majority of that disease derives from low and middle income countries. And so that's one of the reasons for the disconnect. And probably another one is that perhaps there are many that think that there are more opportunities, more gaps in the literature related to other conditions than things like what some might consider more basic neurotrauma or infections. But there are many, many exceptions to that rule. And I think epilepsy is a great example of one of those. We know that the burden of epilepsy is profound, and more so in low resource settings than in high resource settings. And there's just an explosion of questions and research that are going on in the realm of epilepsy. There is a lot of focus on that, as there should be. Mm-hmm. I mean, it's something that I do every day, usually multiple times a day. I think one of the first things is meeting them where they are. So understanding their knowledge of the condition is really important. Getting at their level, sitting down, taking time, and really trying to understand what they know of the situation. Educating them about what's going on and what things they should be looking towards. And then lastly, a really important thing is reassuring them that we will have a plan, that this is something that is brand new to them, but something that we do every day. In those situations, it's our job, or it's my job, to walk them through this journey and reassure them that they will not be alone on that journey. And I think that goes a really a long way to develop trust and let them know that somebody has their back, someone is behind them, and someone can guide them through the process.
How do you balance a patient and their family sense of hope with being realistic about the current situation?
I don't have a specific formulaic answer. I think it's different for every family, every child, but it is just that. It's a balance. There is a need for for many patients to have hope, because we know that that can, from a mental standpoint, from a emotional standpoint, that in and of itself can improve a patient's clinical status. I'm also realistic with patients. But the fact of the matter is that while there are certainly bad diagnoses, bad outcomes, those fortunately are less common than the wins that we have. There are a lot of wins that we enjoy every day, and the wins are more often than the losses. And I think it's important to savor those wins and use those to help take you through some of the losses. But I'm very fortunate to be in a position where I can say that the vast majority of our patients do well and have good outcomes and are better off than they were before.
Thanks for watching and being a part of this journey to improve brain and spine health around the world. If you found this video helpful, please give it a like, share it with someone who might benefit, and subscribe to our channel for more free educational content. And if you believe in our mission, visit brainandspinegroup.org to make a donation today.